Constipation in children is a decreased stooling frequency or increased difficulty of passing stool, as compared to a child's baseline. Normally, full-term neonates pass meconium, which is the very first stool, which is usually thick and green-black, within the first 48 hours of life. Premature neonates, meaning those born before the start of the 37th week of gestation, can take a bit longer. After that, during the first 3 months of life, infants have about 2 to 4 stools a day. By the age of 2 years, toddlers generally have 1 or 2 stools per day. And by age 4, children typically have 1 bowel movement per day. If a neonate does not pass meconium within the first 48 hours of life, has abdominal distension, refuses to feed, or has bilious vomiting, it should raise suspicion for imperforate anus, meconium ileus, and HIRSCHSPRUNG'S disease. In an imperforate anus, there's a non-patent or tiny anal opening, which is anteriorly displaced relative to the base of the scrotum or vagina. In some cases, there can also be a fistula between the rectum and the urethra, bladder, or vagina, through which some meconium might drain. About half of the neonates with an imperforate anus also have other congenital anomalies associated with VACTERL syndrome. VACTERL stands for vertebral defects, anal atresia, cardiac anomalies, tracheoesophageal fistula, esophageal atresia, renal anomalies, and limb anomalies. So the next step is to perform a posterior, anterior, and lateral view X-ray of the sacrum, called a cross-table X-ray. This can help distinguish between a high-type or low-type defect, meaning that the intestine ends high or low in the pelvis, and whether it's associated with other sacral abnormalities. In addition, an ultrasound of the spine, heart, abdomen, and limbs are needed to look for the vertebral, cardiac, renal, and limb abnormalities. Also, an NG tube can be placed and a chest X-ray can be obtained to look for signs of tracheoesophageal fistula and esophageal atresia, like the NG tube coiled in the upper esophageal pouch. Treatment of an imperforate anus begins with a decompression and aspiration of the contents of the gastrointestinal tract through the nasogastric tube, while giving IV fluids and keeping the infant NPO, nothing by mouth. Neonates with a low-type imperforate anus that have no other major defects or comorbidities can have perineal anaplasty done right away to create a new or widened anal opening. Neonates with a high-type imperforate anus or with other major defects or comorbidities, a perineal anaplasty would be too risky at this point. So they typically have a colostomy first to divert the stool. The child is then able to grow and develop before they're ready for the anaplasty, which usually takes 3 to 6 months. Finally, several months later, after the new anus has matured, the colostomy might be closed. Meconium ileus is a condition where the meconium is even thicker and stickier than normal, so it gets plugged in the terminal ileum. This most often happens in neonates with cystic fibrosis, whose GI secretions are extremely viscous. In some countries, the diagnosis of cystic fibrosis can be based on a newborn screening test. But if testing hasn't been done already, diagnosis of cystic fibrosis requires an abnormal sweat chloride test with a level above 60 millimoles per liter, having 2 cystic fibrosis-related mutations, or an abnormal nasal potential difference. In a meconium ileus, rectal examination reveals an empty rectum with no meconium, but with a normal anal sphincter tone. And this is a surgical emergency, because it can lead to bowel perforation, peritonitis, and septic shock, which can ultimately cause organ failure and death. If a baby is septic, the vital signs show temperature instability, either a fever or hypothermia, tachycardia, tachypnea, and hypotension. And there's typically a distended and rigid abdomen, and a baby that looks mottled and lethargic. In a meconium ileus, abdominal x-rays show dilated bowel loops and air fluid levels proximal to the obstruction, along with a soap bubble or ground glass appearance at the site of the obstruction, due to small air bubbles mixed in with the meconium. There can also be linear or curved calcifications, which are a sign of calcified intraperitoneal meconium, in the case of meconium peritonitis. If the diagnosis is still unclear, then a water-soluble contrast enema can be done, and it would typically show a small caliber colon or microcolon along with little masses of meconium plugging the terminal ileum. Treatment of a meconium ileus requires decompression of the gastrointestinal tract through the nasogastric tube, while giving IV fluids. After that, if there's no perforation and peritonitis, then a hypertonic contrast enema can be given to break up the meconium. If that doesn't work, or if there's perforation and peritonitis, then surgery is needed. HIRSCHSPRUNG'S disease is also known as congenital aganglionic megacolon. Here, the ganglia, or clusters of nerves of the myenteric or Auerbach's plexus, and the submucous or Meissner's plexus, which normally coordinate smooth muscle contraction and relaxation, are missing. The rectum and the distal sigmoid colon, which are the areas closest to the anus, are usually affected. Meconium builds up before the obstruction, which causes colon dilation or megacolon, which in turn is a risk for rupture. For diagnosis, rectal examination will show a tight anal sphincter. Sometimes this might be followed by an explosive release of gas and stool, due to temporary relief of obstruction. Next, an abdominal X-ray with contrast dye might show a clear transitional zone between the narrow aganglionic distal bowel and the proximal distended normal bowel. Anorectal manometry can also be done, in which the rectum is dilated with a balloon, showing failure of the anal sphincter to relax. A definitive diagnosis is provided by a rectal suction biopsy of the narrowed area in the colon. During this biopsy, both the mucosa and submucosa are extracted, as opposed to just the mucosal layer because the plexuses are in the muscle layer or submucosal layer. Treatment is typically surgical resection of the aganglionic part of the intestines. Following this, the healthy end is connected to the anus. Alright, now constipation in older children is usually due to functional constipation, meaning that it's due to dietary factors, like a low fiber diet and decreased fluid intake, or behavioral factors, like anxiety, anticipatory fear of painful stooling, or embarrassment about stooling leading to voluntary holding. The longer the stool is held, the more water gets absorbed, so the harder the stool gets passed when the time comes. Functional constipation is defined by the Rome 3 classification criteria, which require 2 or more of the following features for at least 1 month in infants and toddlers younger than 4, and at least 2 months in children older than 4 years old. These features are 2 or fewer defecations per week, at least 1 episode of fecal incontinence per week after the acquisition of toileting skills, history of prolonged voluntary stool retention, history of painful or hard bowel movements, presence of large fecal mass in the rectum, which is usually felt in the left lower quadrant, or history of large diameter stools that might obstruct the toilet. In the minority of situations, constipation is due to other factors, like medications, like anticholinergic agents like antihistamines, and cation-containing agents like iron supplements, as well as underlying disorders, like metabolic and endocrine disorders, like hypothyroidism and renal failure, electrolyte imbalances like hypercalcemia and hypokalemia, neuromuscular disorders like spina bifida, and colon diseases like inflammatory bowel disease. On examination, stool might be felt in the left lower quadrant, and a rectal exam might reveal a decreased anal sphincter tone in the case of spina bifida, and hair tufts or dimples in the buttock area might also be a sign of spina bifida. Also, anal fissures might explain why the child is voluntarily withholding stool because of pain. Now, in most cases, constipation is functional, so no workup is needed. But if there is any warning sign pointing us toward an organic cause, we might additionally order lab tests like TSH, T4, and T3 for hypothyroidism, BUN and creatinine for renal failure, calcium and potassium levels for electrolyte disorders, and CRP for inflammatory bowel disease. Imaging studies like an abdominal X-ray or ultrasound can also be done to assess the colon and rectosigmoid area, in case bowel disorders are suspected. They can also have a spinal X-ray or MRI to rule out other underlying causes, like spinal or neurological abnormalities, and finally, very rarely, a colonic transit study, which can help rule out motility disorders by measuring how quickly the ingested material moves through the colon. Treatment of constipation starts with initial disimpaction of the lodged stools. In young toddlers, this can sometimes be done with rectal stimulation with a rectal thermometer. If this is not successful, or if the child is older, manual disimpaction might be needed. Alternatively, medications can be used. They can be given rectally, like glycerin or bisacodyl suppositories, given as 1/2 to 1 suppository every 12 to 24 hours, or orally, like osmotically active carbohydrates like prune juice, 1 to 3 milliliters per kilogram per day divided twice daily, or osmotic laxatives like propylene glycol, 1 to 1.5 grams per kilogram per day for 3 days. In extremely severe cases, propylene glycol can be given through an NG tube at a high rate, like 25 to 1,000 milliliters per kilogram per hour for 4 hours. But most importantly, maintenance therapy of constipation includes diet modifications, like increasing the consumption of whole grains, fruits, and vegetables, with a recommended fiber intake of 0.5 grams per kilogram per day up to 35 grams per day for all children, and ensuring adequate fluid intake. For infants between 3.5 and 10 kilograms, the daily fluid requirement is 100 milliliters per kilogram. For children 11 to 20 kilograms, it's 1,000 milliliters plus 50 milliliters for every kilogram over 10 kilograms. And for children heavier than 20 kilograms, it's 1,500 milliliters plus 20 milliliters for every kilogram over 20 kilograms, up to a maximum of 2,400 milliliters daily. Behavior modifications are also useful, like regular toilet sitting, twice a day for half an hour, regardless of whether they feel the desire to go, and having parents keep a stool diary to track the date and time the child passes stool and use a reward-based system for toileting, like a sticker chart. Alright, as a quick recap. Failure to pass meconium within 48 hours might be due to imperforate anus, which is diagnosed with inspection of a missing anal opening and a cross-table x-ray. Imperforate anus is often associated with VACTERL syndrome. If it's a low type with no comorbidities, then it's fixed with a single perineal anaplasty. But if it's a high type or has severe comorbidities, then a colostomy is done, followed by an anaplasty, and closure of the stoma in a third operation. Meconium ileus in infants with cystic fibrosis known through a newborn screening will have an empty rectum with normal anal tone on rectal examination. It's diagnosed with an X-ray showing soap bubble or ground glass at the site of obstruction, and is treated conservatively or with hypertonic enema. If there's perforation and peritonitis, calcifications might be seen in the X-ray and surgery is needed. HIRSCHSPRUNG'S disease will have an empty rectum with an increased anal tone on rectal examination, and it's diagnosed with a rectal suction biopsy of the mucosa and submucosa, and is treated surgically. In older children, constipation is usually functional, due to diet or behavioral factors, defined by the Rome 3 criteria. On occasion, it can be due to medications, like antihistamines and iron supplements, metabolic and endocrine, neuromuscular, or intestinal disorders. It's diagnosed clinically, but if an organic cause is suspected, lab tests might be needed, like thyroid function tests to rule out hypothyroidism, renal function tests for uremia, electrolytes for electrolyte disorders, and CRP for inflammatory bowel disease. Imaging tests can also be done, like an abdominal X-ray or ultrasound for bowel disorders, a spinal X-ray or MRI for spinal or neurological abnormalities, or a colonic transit study for motility disorders of the colon. Treatment consists of the initial disimpaction through the rectum, with rectal stimulation, manual disimpaction, or suppositories, or through the mouth, with oral osmotically active carbohydrates or osmotic laxatives, or through the NG tube with propylene glycol. Maintenance therapy is also necessary to prevent constipation in the long run, including a recommended fiber intake of 0.5 grams per kilogram per day, to a maximum of 35 grams per day. For infants between 3.5 and 10 kilograms, the daily fluid requirement is 100 milliliters per kilogram. For children 11 to 20 kilograms, it's 1,000 milliliters plus 50 milliliters for every kilogram over 10 kilograms. And for children heavier than 20 kilograms, it's 1,500 milliliters plus 20 milliliters for every kilogram over 20 kilograms, up to a maximum of 2,400 milliliters per day.